well, I think we're right past 1, so now would be a good time. It looks like there are a good number of people here. So yes, so it's my honor today to present our speaker, Dr. Sergio Huerta. Dr. Huerta is an associate professor of internal medicine at the University of New Mexico Hospital, and he is board certified in internal medicine and addiction medicine. In addition to his work at UNMH, Dr. Huerta serves as medical director of Recovery Services of New Mexico, which is the state's largest opioid treatment program. This program provides treatment for opioid use disorder in urban, rural, and incarcerated settings across the state of New Mexico. He is a strong advocate for increasing equality and access for addiction treatment, and serves on county and national boards developing guidelines and policies to improve addiction care. As a hospitalist, Dr. Huerta has championed several inpatient substance use disorder quality improvement projects. He currently serves as the Principal Investigator for the Substance Use Treatment and Recovery Team, or START, study at UNMH. This NIDA-funded multi-site randomized controlled trial aims to evaluate the outcomes of inpatients seen by an addiction medicine consult service compared to usual care. So thank you so much, Dr. Huerta, for sharing your great knowledge with us.
Thank you too. Thank you, Dr. Jacobson, for that intro. And thank you all for having me here today. This is really exciting. I also wanted to especially thank Drs. Bott and Dr. Quinn for helping advocate for expansion of inpatient substance use treatment here at UNMH, and for really giving me the opportunity to talk with you all today. I'm very excited to discuss expansion of inpatient addiction treatment. This talk is going to go over general principles of inpatient addiction medicine consultation. However, it's specifically targeted at improving inpatient addiction care here at UNMH. My goal is to really create a burning platform for us all to collaborate on creating an addiction consult service here at UNMH. So with that, let me go ahead and share screen here. Can you all see that okay? All right. I'll try to keep my eye on the chat too, so feel free to ask questions if you'd like. So I don't have any disclosures. The objectives for today's talk are to recognize that hospital admission is a reachable moment for addiction treatment, review current literature evaluating inpatient addiction medicine consultation, and demonstrate the need for inpatient addiction medicine consultation here at UNM Hospital. A presentation about building pathways would not be proper unless it included a roadmap. So here's our roadmap for today's talk. We're going to start with an introduction and case presentation. We'll go over the current state of inpatient addiction treatment at UNMH. We'll highlight some of the evidence supporting inpatient addiction consultation. And we'll review a proposal for inpatient addiction consultation here at UNM. And hopefully we'll leave plenty of time for discussion and questions at the end. I wanted you to be introduced to a patient of mine named Justin. He's an actual patient that was gracious enough to let me share his story with you today. Justin is a 35-year-old male with a history of PTSD, anxiety, and opiate use disorder. He began using heroin IV at age 23 while incarcerated at New Mexico State Prison. He had tried quitting opioids in the past, but had never been on medications for opiate use disorder, also known as mood, such as buprenorphine or methadone. He was very interested in starting buprenorphine or Suboxone, but unfortunately, this treatment is not offered at any New Mexico prisons. He's eventually released from prison without any treatment for his OUD and continues to use IV heroin. Shortly after release from prison, he presents to the UNMH emergency department with left arm erythema and edema. His vitals are consistent with tachycardia and fever. His labs reveal an elevated white count, and his urine toxicology is consistent for opioids. He is diagnosed with sepsis secondary to left upper extremity abscess. He's admitted to UNM Hospital. His abscess is drained, and he started on antibiotics, kind of the standard of care for an abscess. During his hospitalization, he initially suffers from mild opioid withdrawal and some pain at the abscess site, which is treated with oxycodone. On hospital day 3, his white count subsides. He's afebrile, and his wound looks to be healing well. His medical team feels that he is ready for medical discharge. His withdrawal symptoms, on the other hand, have worsened. Although his medical team does not offer him any medications for opioid disorder, he tells the team that he's interested in Suboxone. However, no one on the medical team is wavered to prescribe outpatient buprenorphine. The team also does not know where to send Justin for a quick follow-up appointment if he is sent out on Suboxone. The team's care manager also is not sure where to send Justin out for an outpatient Suboxone follow-up. The team decides not to start Suboxone, but instead gives him a list of SUD clinics in town and encourages him to set up his own appointment. When he gets home, he tries calling several clinics from the list, but appointments are weeks out, and Justin is without treatment and continues to use opioids. Unbeknownst to him, he begins to use fentanyl-laced heroin, and within a few weeks suffers an opioid overdose. Fortunately, his friend is able to administer naloxone at the scene, and he is quickly rushed back to the UNM emergency department, where he is readmitted to the hospital. Justin's story exemplifies some of the current standards of care for inpatient addiction treatment. OUD can be identified on admission. There are often barriers to starting treatment and coordinating follow-up. This results in a missed opportunity to engage patients in treatment and can lead to poor patient outcomes and increased healthcare utilization. These scenarios have become even more commonplace as the number of OUD-related hospitalizations has increased. This graph shows the national number of opioid-related inpatient stays per year. And perhaps not surprisingly, the rates of opioid-related hospitalizations have increased over the past decade. National ED visits for OUD have similarly increased yearly in the past decade as well. In fact, the rate of ED visits as compared to inpatient admissions has been on an even higher increased rate. When looking at New Mexico, we can also see that inpatient hospitalizations for OUD have also increased in the past decade as well. And when you compare New Mexico to the national average, inpatient OUD admissions in New Mexico are actually higher than the national average. This map of the US shows inpatient stays for OUD, and darker colors indicate higher rates of inpatient OUD admissions. And you can see that New Mexico is the darkest blue state in the Southwest. Drug overdose death rates have also been increasing over the past decade. Last year, the United States had its highest drug overdose death rate ever recorded in history. Roughly 92,000 deaths were attributed to overdose in 2020. And sadly, in New Mexico, drug overdose death rates have consistently increased and been higher than even the national average. This spike in overdose death rates is primarily attributed to synthetic opioids like fentanyl. This is a figure from NIDA looking at national drug overdose death rates. The blue line that spikes up in 2015 represents fentanyl. So you can see that it's the main contributor to drug overdose death rates nationally. Here in New Mexico, fentanyl and methamphetamine are the main contributors to overdose deaths. In this graph, the red line is fentanyl and the orange line is methamphetamine. And you can see that both have been increasing yearly and peaked in 2020. This increase in overdose death rates and hospitalization can be reduced with treatment. However, the majority of New Mexicans with substance use disorder are not on treatment. In fact, it's estimated that 200,000 New Mexicans have a substance use disorder, and 65% of those are not on any form of treatment. So how do we get more people engaged in treatment, right? That's the question. And really, we have to tip the scale. We have to make getting treatment easier and more available than street access to other substances. We need to eliminate as many barriers to starting treatment as possible in order to tip the scale in favor towards treatment. One way that's been proposed is utilizing emergency departments and hospitals as entry points for SUD screening and treatment. And this is actually recommended federally by SAMHSA, or the Substance Abuse and Mental Health Services Administration, and the state, the New Mexico Department of Health, also is recommending that hospitals are utilized in this fashion. So if this is what the recommendations are, how is our hospital being utilized to close this treatment gap and provide access to treatment? Well, in order to better understand this question, we performed a two-parts needs assessment. The first part of the needs assessment was an inpatient SUD data query that was based on ICD-10 coding. This was performed in summer of last year and looked at data from 2020. And we only reviewed data for alcohol use disorder and opioid use disorder, as these were the two main substances with the most usage at UNM. And then we also did a second part, which was the needs assessment of an inpatient provider survey. And this survey was emailed via REDCap and assessed inpatient substance use disorder beliefs and attitudes. And the survey was conducted around the same time as the data query. For the data query, looked at three things: the number of admissions for substance use disorder, discharge medications for substance use disorder, and just quality metrics around substance use disorder. So in 2020, 1 in 10 admissions had an AUD-related diagnosis code at UNM Hospital. 1 in 20 admissions had an OUD-related diagnosis code. And what's really important to note about this too is that this data is solely based on ICD-10 coding. So there's evidence in the literature that actually supports that usage of this methodology can severely underrepresent the actual number of patients with SUD. So we believe that these numbers are actually higher than what's shown here. To get a better sense of the treatment we provide at UNMH, we reviewed the discharge medication list for patients with AUD and OUD. And this allowed us to see if patients were started on treatment during their hospital stay and if the treatment was continued when they left. And what we found was a significant treatment gap when we reviewed these discharge medication lists. So when you look at patients with AUD on their discharge medication list, we found that only 6% of patients were discharged on any form of FDA-approved medication for alcohol use disorder. When we reviewed the patients who had OUD on their discharge medication lists, we found that only 15% of patients were discharged on any form of FDA-approved medications for opioid use disorder. And sadly, we also found that 22% of patients with the diagnosis code of opioid overdose were discharged on Narcan, which means 78%, of patients with an opioid overdose are not sent out with Narcan. For the last part of the data query, we reviewed some quality and operational metrics for substance use disorder. And when you compare patients with substance use disorder to all admissions, the following was revealed. So patients with substance use disorder have higher rates of readmission. So this is consistent for both alcohol use disorder and opioid use disorder as well, when compared to just general admissions at the hospital. Patients with alcohol use disorder actually had a higher length of stay, so they were in the hospital for a longer period of time compared to patients without alcohol use disorder. And patients with opioid use disorder had longer ICU stays, usually primarily related to infectious disease consequences of usage, compared to the average of standard hospital admissions. So important quality metrics have also been affected by substance use disorder. The second part of our needs assessment was a provider survey. So it was modeled after similar surveys in the medical literature. We got about 175 respondents to this survey. And what I want to do is just highlight some of the key responses from the survey. So the majority, or 60% of respondents, felt that patients, these are inpatients, with substance use disorder experience stigma at UNM Hospital. A minority, so only 38% and 30% of respondents felt comfortable starting medications for AUD and OUD respectively. Only 11% of respondents felt that patients with substance use disorder receive appropriate follow-up. and only 10% of respondents felt satisfied with the treatment patients with substance use disorder receive here at UNM Hospital. And these results were surprising, given the fact that the majority, or 93% of respondents, actually encounter patients with SUD on a daily basis. And when asked bluntly, the majority, 94% of all respondents, felt that an addiction consult service is needed at UNM Hospital. These are some selected provider comments from the survey. So we also had a section where they could free text some answers. I just highlighted a couple of them. They were all similar in vein. So this is a surgery attending. We do a very poor job of identifying and treating patients. A formal consult service would be incredibly useful and would be a great opportunity for intervention. An OB-GYN attending said the medical complications are addressed, however, the counseling and follow-up are not. And an ED attending said, there are many repeat patients with substance use disorder and the resources are limited. So going back to our roadmap, it's clear that there's a treatment gap at UNM Hospital and there are barriers to providing treatment. But is there actually any evidence that addiction consultation can address these barriers? So I think we all can agree, and there's strong evidence to support already in the medical literature, that medications for opioid use disorder in the outpatient setting have numerous benefits. So the use of medications for opioid use disorder or mood, including buprenorphine, methadone, naltrexone, are really the gold standard. And this is because patients who are initiated on mood reduces mortality and overdose death rates, reduces opioid usage, increases retention in treatment, also improves infectious disease outcomes, specifically with HIV and hepatitis C, reduces criminal justice involvement, and is cost effective. So these are all things that are focused on the outpatient setting for mood. But really the big question is hospitalization the right time to intervene for these patients? And hospitalization should be viewed as a reachable moment for SUD care. So there was a study that was done out of OHSU, which I think is the name of their addiction consult service is Impact. So one of their preliminary studies that was done surveyed several hundred patients that were at OHSU, and this is what they found. They found that 68% of patients with substance use disorder and 53% of patients with alcohol use disorder actually wanted to cut back or quit. Many of these patients wanted medications for addiction treatment, and they wanted treatment to start in the hospital. So from this data, we can see that hospital admission can be a critical moment to engage patients in treatment for their substance use disorder. Not only is hospitalization a reachable moment, but there's emerging research that supports the usage of inpatient addiction consultation. So for OUD specifically, there have been several studies. There's been 3 retrospective cohort studies, 2 prospective cohort studies, and 1 RCT that all show inpatient initiation of medications for opioid use disorder results in declines in opiate use disorder at 30 days post-discharge, increases the likelihood of addiction treatment entry and retention, increases the likelihood to complete medical treatments, and decreases the likelihood of 90-day readmissions. So really, it can be clear that hospital-based OUD treatment is effective. These are the studies that all support that. But what about alcohol? We've been talking a lot about opiates. What about alcohol? There's also evidence to support that addiction consultation for AUD is effective as well. So this is a study out of UCSF, which also has an addiction consult service. Patients were initiated on naltrexone during admission for alcohol use disorder. And they found that patients in this population, both 30-day and ED readmissions, decreased for the naltrexone group compared to the non-naltrexone group. So these next few slides are really busy, but I wanted to demonstrate the emerging evidence to support addiction consultation. So these are all the studies. Some of them are observational, but just to show kind of what's out there. Most of these things have been published in the past few years because this is kind of still a novel concept in some ways. I think some of the first consult services were created back like in 2017 or so. So it's a few years old. But when you look at healthcare utilization, when it comes to consult services, there are several things that come from benefit-wise from usage of addiction consult services. So we had already mentioned some of these things, but reduce avoidable admissions and readmissions. And this is actually the highest level of evidence that I could find from all the studies. This is actually where one of the RCTs was performed, actually showed a reduction in 30-day readmission by almost 15% in the intervention group. Also, it reduces length of stay, reduces ICU days, reduces AMA discharges or against medical advice discharges, and reduces emergency department visits as well. What about patient outcomes? Well, when you look at addiction medicine as an intervention, you can see that for patients who have been seen by an addiction consult service, they actually had reduced opioid overdose death rates, improved linkage to care. They had increased completion rates, inpatient completion rates of their IV antibiotics, increased treatment uptake and reduced outpatient substance use usage. And they also, there was one small study that showed they had increased patient experience as well when they actually had providers paying attention and caring for them for their specific substance use disorder. Another thing that I thought was pretty interesting when it comes to the benefits of addiction medicine consultation is that these benefits spread beyond patient and even hospital. They actually affect the providers as well. So some of the benefits include reduction in provider stigma, improved training knowledge for residents and fellows, as well as increased provider satisfaction as well. So there are numerous benefits to inpatient addiction medicine consultation, as evidenced by the literature. On the topic of evidence and research, I wanted to make a quick plug for the START trial. Dr. Jacobson mentioned this earlier, but what is START? So START stands for Substance Use Treatment and Recovery Team. And I mentioned just a moment ago that there's been only one randomized controlled trial when it comes to addiction medicine consultation. And I'm proud to say that UNM is one of 3 sites that's current for an NIH IRB approved randomized controlled trial. So this is a pretty novel thing when it comes to addiction medicine treatment. And really what the intervention is an addiction medicine consultation versus the standard of care. So patients are randomized to see myself and a care manager versus whatever is typically done in the hospital setting. And the endpoints for this include in-hospital medications for opioid use disorder initiation, linkage to care 30 days after seeing the consult service, and then looking at 30-day opioid usage upon discharge. And really my role in this is, seeing the patient, doing the initial consultation, and starting medications if the patient's interested. And then the care manager, who's also part of the team, does some substance use specific counseling and also coordinates their follow-up post-discharge. This started just recently, and we're looking for about a 10-month intervention that will end in October 2022. We are actively enrolling patients right now. And my hope is that this START trial itself will really be a pilot program of sorts to see how an addiction consult service here at UNM can really benefit patients, and if there really are benefits of these services here specifically at our site. So let's get back to our roadmap. We've seen that there's a treatment gap for admitted patients at UNMH, and that addiction consult services can be a potential solution for this. And I wanted to share a proposal that our team has been working on to help address this issue. So hospitalization is a reachable moment to engage patients suffering from substance use disorder in treatment and arrange their outpatient follow-up. Caminos is a Spanish word for pathways. And really what it is a reflection of the vision of creating an inpatient to outpatient pathway for care here at UNMH. So what is Caminos besides a pathway? Well, they always have, it's always nice to have a nice acronym when you come to some of these things, right? So CAMINOS stands for Coordinating Addiction Medicine with Inpatient and Outpatient Services, right? So it's really building that pathway between these two things. And CAMINOS is really a pathway that will eliminate these roadblocks to treatment and hopefully improve patient outcomes. So who's part of the CAMINOS team so far? Well, it's so far the CAMINOS proposal has been a collaborative effort between multi-departments here at UNM Hospital. It includes several members of hospital medicine, but it also includes Drs. Bott and Quinn here in psychiatry, as well as Dr. Carejo in family medicine and Dr. Warwick in emergency medicine. And if you're interested in this, please email me. I'm happy to collaborate and get more buy-in from everybody else too. What's great is that this consult proposal has the support of the chiefs of emergency medicine, internal medicine, family medicine, and psychiatry. So thank you, Dr. Tolan, for supporting this endeavor. And we'll just kind of go over broad strokes here, but the structure of this is that it's meant to be a multi-departmental interdisciplinary team that's staffed by clinicians from all of these departments, really combining all our efforts to provide the best care for patients with substance use disorder who are admitted to the hospital. It will be comprised of physicians, advanced practice practitioners, a social worker, a peer recovery support staff, learners, residents, and hopefully fellows as well. And the service would be offered for all patients with substance use disorder. So this would include alcohol use disorder, opioid disorder, but also stimulants and sedative use disorders as well. Clinically, it will help create universal screening for substance use disorder. So all patients who are getting admitted to the hospital will hopefully get screened and get identified for a potential intervention at that time. But it would also provide treatments and assessments, including withdrawal management, medications for substance use disorders, specific substance use disorder counseling, and even harm reduction pieces as well. It would also primarily be a real vessel to provide post-discharge follow-up and help bridge the gap between these two, the inpatient and the outpatient services. But even beyond the clinical aspects of such a service, the service would offer various additional benefits as well. So it would improve the education of trainees. I can see medical students and residents rotating through this service, as well as providing an in-service inpatient piece for addiction medicine fellows. It also is ample for quality and research opportunities, just like the START program, seeing how inpatient interventions in this emerging new study field, there's plenty of opportunities to really research this and let UNM be a kind of leader in some of these areas. It will also provide institutional-wide protocols and procedures for patients with substance use disorders, so helping streamline those processes. But perhaps most importantly, I think, the consult service would aim to improve the culture surrounding substance use disorders at the hospital and across the HSC, right? So really promoting equitable care at the hospital. And, you know, all of these services, all of the things we're envisioning that a service would entail, all align with the UNM HSC goals, right? So providing high quality comprehensive care, creating new educational endeavors, fostering research opportunities, promoting equitable treatment, and developing community partnerships. These are all things that are native to the creation of a consultative service. And I think by doing all these things, we will, you know, be adhering to the goals of the institution as well. So where are we at with this? Well, the CAMINOS proposal has been submitted to UNM Hospital leadership. A few months ago, we met with Drs. Agostini and Rankin to discuss this, and it's kind of being discussed currently. So we're waiting to hear a response from them. Also, we mentioned the START trial and its anticipated end date in October. So we're really using this as kind of that pilot study to see how things go here. And the goal is to use that data from the START study to help leverage the production or usage of an addiction consult service at UNM So hopefully we can look at some of these quality metrics, readmissions, length of stay in the intervention group, also billing and things of that nature, but also patient outcomes to see if there's really change here at the hospital. And what's great too about the START trial that's ongoing right now is that the care manager that's part of this process is already building community partnerships with outpatient SUD providers, including opioid treatment programs, detox centers, other OBOTs or but really other next steps is focusing on collaborating with key stakeholders, right? So this includes other departments and speaking to you all from psychiatry to develop outpatient linkage programs, treatment protocols, curriculum measurements, all these different things really work together and collaborate to build something special, as well as linking up with community partners across the state. We all know that there are patients that come from all over the state of New Mexico to come here and get treatment. And if we start them on SUD treatment, we need to make sure they get linkage, even if they live outside of the Albuquerque area. So as we near the end of the presentation, I wanted to circle back to Justin really quick. So if you remember him from earlier on. So he was admitted to the hospital a second time. But this time, the hospitalist service actually started him on Suboxone when he was there at the hospital. And he's been following me ever since. This has been about a year at my outpatient clinic ever since discharge. And he's doing fantastic. He couldn't be happier. In fact, he actually wrote a card to the clinic, and I wanted to share that card with you all today. Without all of you and this program, my success would not have been possible. I want to thank you for all your efforts and dedication to really changing people's lives. I never thought I would ever see the day that drugs don't cross my mind anymore. I was given a second chance at the life I deserve and want you to know that I share this success with you. I couldn't have done it without you. Today, I'm not only clean from heroin, but shortly after my meth addiction followed suit. Thank you, and I love you all. I'm sure some of you that treat patients with substance use disorders can feel similar responses sometimes from the treatment that you get. So in summary, UNM Hospital is facing a significant substance use disorder treatment gap. Right, so the majority of patients that are admitted with substance use disorder are untreated. And we know that hospitalized patients with untreated SUD have worsened healthcare outcomes and higher healthcare utilization. Addiction consult services, like the proposed Caminos, will offer specialized treatment for patients with substance use disorder and can help address this treatment gap. These are evidence-based and have been shown to improve healthcare outcomes and healthcare utilization. So for our discussion today, I wanted to ask you and your group, how can we work together to help solve this problem? Because together we can really build that Camino or pathway between the inpatient and outpatient addiction treatment here at UNM Hospital. So thank you very much for your time.
Thank you so much, Dr. Huerta. That was wonderful. And I'm sure that there's some questions in the chat, and I'm sure people have some discussion and questions. So please go ahead and unmute.
Sorry, I couldn't read all the chat stuff while I was talking, but I'm happy to.
Oh, no worries. Can you see it now, Sergio? It looks like there is a question. What type of MAT are you providing to patients? That's one question that came up.
Yeah, so currently within the START trial, all forms of FDA-approved medications can be offered for patients with opioid use disorder. So right now, we've had about 6 patients in the intervention group so far, and the majority of them have been put on methadone, primarily because they have co-occurring pain as well, or they've been on methadone before in the past, so they want to continue trying that. But we've had a few buprenorphine patients as well too. And just to know, if a patient is not interested for the trial in starting any of these medications, they are given plenty of resources and counseling here, and then they're actually given a follow-up appointment if they'd like to do that, even for just counseling and stuff too at discharge.
Great, thank you. It looks like there's from Dr. Zidonis about addressing tobacco. Do you see that one as well?
Yes. Yes, I think that would be a part of also the standard of care that comes for all of these addiction consult services. I think most of them, when you look at the literature, also address co-occurring tobacco use disorder. We know that patients with substance use disorder have a high prevalence and incidence of usage of tobacco use. So I think it's a great point. And I'm pretty sure that one of the main drivers also for this service will also be addressing that too.
Yeah, and thanks, Dr. Correjo mentioned more tobacco treatment program being developed, more to come. Dr. Armstrong, what about a residential treatment program at UNMH?
I think it's a great idea. And I think, there's so much great work that's being done here all across the HSC, right? So you have stuff outpatient done with family medicine, internal medicine, as well as psychiatry. You have a lot of research done at ASAP as well too. You have the OTP there. You have the whole CASA program as well. I mean, there's all these different great pieces that are going on. I just think this could be an additional piece to all of those things as well, and really provide a linkage piece as well and start building upon these things to even further increase access.
Sergio, can I comment on something?
Absolutely.
Hi, I'm Valerie Correjo. I'm the program director for the Addiction Medicine Fellowship. And as we were developing this proposal for the consult service, one thing always comes to my mind as a more outpatient focused provider, and that is starting patients on inpatient treatment doesn't work if we don't have a place to send them outpatient and sustain them on treatment. And I think that has to be multi-specialty: psychiatry, family medicine, internal medicine, pediatrics. Everybody, I think, needs to be able to accept patients, treat patients, and then have a more fluid access to higher levels of care. For example, someone who's not doing well might need to go to ASAP, and we need to get them in quickly and get them seen and stabilized and maybe sent back out to community providers. So just a plug for everyone to participate on the ambulatory side as well.
Dr. Correjo, this is Davin. Can I piggyback on that? Thank you for saying that. I, been trying to encourage all our faculty to get the buprenorphine, license to be able to provide this. And I just wonder if you and Dr. Huerta perhaps could provide some inspirational words, or just about, like you presented, the gratitude that the patient has for being able to be on a life-saving treatment like that is so easy for us to provide and takes so little effort and is so impactful. Can you speak to just sort of how impactful that would be for us to get our licenses?
I definitely can. I got my buprenorphine waiver training when I was a resident, and I was the only person in my residency class to do so. Right after residency, I went into the first choice clinical system where I was the only prescriber, and I started off with 10 patients. And I actually still have at least 4 of those patients who remain in prolonged recovery now 15 years later. And just having seen them kind of, and many, many patients in between. We have sad stories where we lose people who might have relapsed and overdosed. We have sad stories where some people just can't get quite where they want to be in their sobriety, but so many more patients do well and they turn their lives around. And we see, with Larry's on here today too, with the Milagro program, women who become pregnant and stop using, and they are developing their young families in our focus programs. It's just so many positive things, and we can't quote unquote cure it, but it's so much more rewarding to see a patient in prolonged recovery on a substance use disorder than constantly seeing a patient with a hemoglobin A1C of 9 or 10 and constantly having to adjust their diabetes medicines and things like that. So I really feel strongly that it's a rewarding piece of practice, and it's not very hard compared to a lot of the work that we do in ambulatory.
Thanks, Dr. Carrijo. And Dr. Lehman, you wanted to make a comment?
Yeah, thanks. This is a great presentation. I think it's a great idea that I'm excited about too. I think it's really timely, and given what's happening with fentanyl, we're finding with Milagro, with our pregnant patients, it's so much harder to get people started on either methadone or buprenorphine as an inpatient. It really has gotten a lot more complex, and so I think this will really be very helpful to be successful. It used to be much easier when everybody was using oxycodone or heroin, but with the fentanyl and meth, I think there's such a need for subspecialty service.
Yeah, thanks for that comment. I think that what would be really great is developing protocols specifically for some of these substances, right? Because right now people are just kind of doing things as is, kind of ad lib when it comes to these things. Especially I've seen it on the inpatient hospitalist service, people trying to do the right thing, right? Start people on methadone, for example, for opioid use disorder, but starting on really high doses. Sometimes people need to have Narcan resuscitation at the hospital. And I think it's just kind of that education piece. And what's really great too is that when you look at some of these services that have been started in the literature, you get that cultural shift too. You get people actually starting to be more engaged in some of these things. To Dr. Quinn's point, you can see that everybody is happier providing these things for patients, that it's relatively pretty easy and straightforward. And once you get this ball rolling, there's a lot of momentum to keep it moving forward. And I think you can see a lot more providers starting to think about this as well as part of someone's actual care and really starting to address those substance use issues.
Yeah, thanks, Dr. Huerta. And thank you, Dr. Quinn, for posting in the chat, just so everyone sees the link there to the waiver. And I wanted to see, Dr. Huerta, there were a few more things above that in the chat, some other thoughts and questions.
Yeah, there's a couple questions about naltrexone. So yes, we are offering that for alcohol use disorder on the inpatient side, but also for opioid use disorder, specifically within the constraints of the START trial. It's kind of hard to get inpatient IM naltrexone. That's something that I think a consult service could be collaborative with. If there's a group of us that really thinks this would benefit and approaches the inpatient pharmacy department and says, hey, this is something we're going to do and kind of develop it, I think they'd be really open to it. In fact, I've approached them before in the past about advocating for Sublocade, which is the long-acting injectable form of buprenorphine, and that actually has been started on formulary currently for inpatient. So I can see that being another potential avenue for patients as well. Specifically to Dr. Vyas's point, so he mentions patients going to nursing facilities, which is a whole nother can of worms. But, nationally, there have been some litigations put on SNFs, or skilled nursing facilities, and long-term care facilities, specifically in Massachusetts, where they've denied people access or admission to a skilled nursing facility if they have a substance use disorder. And that's been deemed a form of discrimination and unfair treatment. So there's been some changes as far as that goes, but unfortunately here in New Mexico, that stigma still persists, and that's really what it is stigma. I've actually worked with a lot of these skilled nursing facilities, and part of what's going on with the START trial right now is helping build those linkages. So patients that are in the START trial that are seen by an addiction service, so this is what's great, is that these SNFs are a little bit more open-minded. If they see a specialist or they see somebody who's a little bit more trained in addiction medicine and has a little bit more training when it comes to those kinds of things when starting medications, that they're actually willing to accept. One of the big ones here in town or in the state is Genesis skilled nursing facilities. They're actually accepting patients after they've been seen in the START trial. And I'm actually helping them get follow-up at the SNF as well while they're there, to help ease that burden to make sure that they're continuing. That way, if we start them on here, I don't want it to be a barrier, because I've seen people want to start patients on medications for opioid use disorder, but they can't because they know they have a skilled need. So really working on these things and continuing to build upon them, I think can only benefit more patients.
This has been great. Any other thoughts or questions? I think we got everything in the chat. And I think, yeah, thank you for Rachel Rose, that as a fourth year medical student, I think I speak, yes, for many of us saying that students would love to rotate through something like this. And I know Dr. Huerta has extensive experience working with the med students, so has probably already figured that out.
I love med students, love residents, love fellows, and I think this is another avenue for potential training and education, because there's a lot of people, a lot of students I've seen that are really interested in this, right? They've never really been taught this before, and it's emerging, and they want to help out. And I think it's great to offer another potential way for them to get education in this area.
Dr. Huerta, can I ask one quick question? You've been
always ask me a question, Dr. Quinn.
Thank you. You've been the intrepid leader of this effort for several years, and I'm just I want to go ahead and sort of ask, what else can we do to help get this to the starting line, to get this service up and running? What do you think? What do you think it needs, and how can we help?
I think from the foundational level, I think really working within the department to help build those linkages to care. Because right now it's pretty easy if you have one or two buprenorphine or even a methadone patient to get them somewhere connected. But my hope is that, if a lot of these patients are being seen, they actually get started on treatment, and where are they going to go once you have this critical mass of patients? And I think in psychiatry, you have a lot of resources, right? You have the OTP at ASAP, you have OBOT clinics as well. So I think within the psychiatry department, and really helping streamline, like Dr. Garejo had said, kind of how we would go about doing this. Not everybody may need to be seen at ASAP. I would see maybe ASAP as more of, like she had mentioned, people with dual diagnosis, stuff like that, they may need additional care. Or if they need to go to a family practice or internal medicine for some additional primary care things, or just a straight OBOT just for buprenorphine follow-up, and kind of working together to collaborate to kind of envision where patients can kind of go through this flow. But I also think you have a lot of great leaders, as always, in psychiatry. And I think, from that standpoint too, leaning on your leadership to see if they will support this and keep that momentum going from the executive level to really support this endeavor too. It's a good question.
Thank you. We'll keep our nose to the grindstone here.
And Dr. Huerta, you see the from Dr. Delmore, the thank you as well in the chat. Thank you through RSMM first. Yes, Dr. Delmore, did you want to go ahead? I don't mean to.
No, I just really, thanks for the shout out. No, I just really appreciate Dr. Huerta's work with the students. And I know many others here on the call also over to ASAP work to precept the students as well. And multiple others too through their other rotations. So thanks for this. This is really important work. So thanks for all you do.
Thank you all. I would love to continue having these conversations, and hopefully as we get more data from the START trial, hopefully at some point kind of sharing some of those data points with you all, kind of seeing where we're going with this pilot kind of service too.
All right. Well, thank you so much, Dr. Huerta, for the wonderful presentation and for all you do.
Thank you guys again. It's great to be here today.